Our next speaker is Dr. Raja Narayanan. If you think Beijing Torrent Eye Center was impressive, he represents LV Prasad Eye Center, which is probably the top eye center in India. And they see also close to 1 million outpatients a year. And he's going to talk about something similar to what Professor Chang has covered. And Raja, please.
Thank you very much. I thank the organizers for giving me the opportunity to present on aflibercept and bevacizumab in retinal vein occlusion. I'll be focusing mainly on branch vein occlusion. We all know historically that we have 4 anti-VEGF agents available in general, starting from pegaptinib to aflibercept, but I'll be focusing on aflibercept and bevacizumab in my talk. So aflibercept is a fusion protein of VEGF-R1 and R2 receptors, and it has a strong binding affinity to VEGF-A, VEGF-B, and placental growth factor. The aflibercept is approved for colorectal cancer. It was approved in 2012 by US FDA, but it can be used off-label for ophthalmological diseases. The major difference between aflibercept and aflibercept is the difference in osmolarity being 1000 milliosmoles per kilogram in aflibercept and 300 milliosmoles per kilogram in aflibercept. We have commonly seen this picture of Lucentis and Avastin, but here I am showing Eylea and Zaltrap. The dose of Zaltrap is 100 milligram per 4 ml, which is about 25 milligram per ml. So if you take 0.05 ml of Zaltrap, you get a dose of 1.25 milligrams. So the key difference here is Eylea, if you inject, it's 2 milligram in 0.05 ml, whereas Zaltrap is 1.25 milligrams. So as I mentioned, the difference in osmolarity is important because way back in 1980, Mike Marmer had published that if the osmolarity of the vitreous increases beyond 500 milliosmoles, it can cause RPE damage in animal eyes. The human eye vitreous volume is a little bit larger than the rabbit eyes, and if you look at the osmolarity of aflibercept of 1000 milliosmoles per kilogram, if you inject 0.05 ml in the human vitreous volume, it gets significantly diluted, and the final osmolarity is about 300 milliosmoles, which is similar to what aflibercept has. Our team, led by Dr. Jay Chablani, published last year on the toxicity and safety of aflibercept in 12 eyes in retina, and we did not find any change on the ERG, as well as clinically there were no signs of toxicity. So coming to our experience of Zaltrap in branch vein occlusion, we have so far in the last 2 years injected 88 eyes, out of which 57 eyes were treatment naive. And if you exclude patients who had better vision than 20/40, we could get a subset of 38 patients for analysis. Out of these, 17 were female. The mean follow-up was 6.82 months, and the mean number of injections was 1.45, which is significantly lower than in what you would expect in a clinical trial. So this was a retrospective study. If you look at the visual acuity, the baseline visual acuity was 20/125, and the final visual acuity is 20/60, which is about 15 letters of improvement. And 42% of eyes gained more than 3 lines. Now, if you recollect various other pivotal trials of branch vein occlusion, the usual gain, 15-letter gainer is about 60%, but here it was 42%. Examples here, this is a patient who had a baseline vision of 2200, and after 1 injection of aflibercept, there was complete resolution of edema, but with any anti-VEGF injection, there was a recurrence in this patient again, and this patient received 4 injections over 12 months, and you can see there's still some fluid at 12 months. This patient had acute onset vein occlusion with vision of 20/60, and with 1 injection, the OCT completely dried up, vision came back to 20/20, and at the end of 6 months, this patient maintained at 20/20 vision. This is another patient who had a baseline vision of 20/100, and with 1 injection, this patient had only a 4-month follow-up, she didn't come beyond that. But at 4 months, there was significantly improved OCT, although there was some amount of ischemia because of which the vision did not improve significantly. So looking at the effect of Avastin in branch vein occlusion from our own study, we had published a couple of years ago as a prospective study the results of Avastin and Lucentis. And what we found was that Avastin had a mean gain of 15.5 letters at the end of 6 months, and the mean number of injections which was given within the first 6 months was 3. So compared to our prospective study of Avastin, the number of injections what we gave in Zaltrap in our patients was significantly less, although it was a retrospective study. So looking at some of the other considerations which I had mentioned, that the dose of ziv-aflibercept is significantly less than aflibercept which is commercially available. We are currently doing studies with 2 milligrams of ziv-aflibercept, but it increases the volume which we have to inject to 0.08 ml instead of 0.05, which could raise concerns on intraocular pressure as well as hyperosmolarity induced toxicity. And so we have looked at our ERG in these patients, of 20 patients. So we did not find any significant changes on ERG as well as the intraocular pressure. Dr. Jay Chablani has also published the cost effectiveness in Asia Pacific Journal of Ophthalmology a couple of months ago. And if you look at the vein occlusion data, it is quite similar to Avastin. The cost per year in US dollars about $240 for Avastin and $260 for ziv-aflibercept with the dose of 1.25 milligram compared to the many hundred times more for aflibercept or ranibizumab. So in summary, ziv-aflibercept may be an option in case of retinal vein occlusion, although it is off-label. The dose of Zaltrap, which is convenient to use, is slightly less than what is available commercially with Eylea, but we are doing currently studies with the newer dose of 2 milligrams in 0.08 ml, and larger prospective studies are required to validate our findings. Thank you very much for your kind attention.
Okay, thank you, Raja, for your nice presentation. Professor Mark Gillies from the University of Sydney. So he's going to talk about steroids for RVO.
Thanks, Shinran. And I note that this is being filmed by Pi Magazine, Asia Pacific's posterior segment magazine, being run by that guy, Matt Young, in the watermelon suit. So what about steroids for retinal vein occlusion? I'll go about where this came from. We developed steroids, I think, in Sydney. The major studies here are the SCORE studies from the NEI, Geneva, these head-to-heads from Novartis, and a real-world study from Yong-Hee's group in Korea. So Philip Penfold and Alex Hunya Sr. started injecting triamcinolone dyes with AMD in the early 90s, and we conducted a clinical trial. We didn't actually find a beneficial effect on AMD for triamcinolone. I think this might have been the first intravitreal injection study ever, but then we did the diabetic macular edema study, and we found a good result here. Over 5 years, basically, you doubled the chance of improvement of letters, vision gain, and you increased the reduction in macular edema, in diabetic macular edema. So steroids can be effective for macular edema. What about RVO? This is the SCORE study where they looked at 1 and 4 milligrams of Trivaris, which is only really used in the NEI studies. We're not quite sure about the pharmacokinetics of this drug. And they compared this to observation for CRVO and laser for branch retinal vein occlusion. Essentially, the SCORE BRVO study found no benefit of triamcinolone here in terms of letters gained over the first 12 months, or the proportion that gained 3 lines. It was the same for laser, and because it had more adverse events, they did not recommend triamcinolone for branch retinal vein occlusion. Excuse me. However, the results for central retinal vein occlusion were much better. We had over a quarter of the patients gaining 3 lines in the 2 dosage groups, with only 7% in the so that shouldn't be good laser, that should be observation alone there. which was these vision improvements were sustained in years 2 and 3. So they did recommend that triamcinolone is effective for central retinal vein occlusion. Then we come to the Geneva studies, quite early on these studies in 2010, where they did branch retinal vein and central retinal vein occlusion. With these inclusion criteria, they had 2 doses of dexamethasone and sham treatment. So essentially, for the whole group, the story with Geneva was that it worked at 3 months. These were 3-month results. They had good improvements in vision, and they had good reductions in central macular thickness compared with sham. However, at 6 months, which was the primary outcome, the drug had worn off, and there was no difference between the two, between the active and the sham-treated groups. And you can see here the mean change in vision from the branch retina, the CRVO patients, a good improvement at 3 months, which had worn off by 6 months. And then when they came and injected again, they got another improvement, and it wore off again by 12 months. You'll note here that the sham-treated eyes, when they received active treatment, they didn't catch up to the eyes that had been treated the first time around. And this is a consistent message with all these studies from retinal vein occlusion, that if you delay treatment, you pay a price and you don't get good results. You tend to lose vision as time progresses. They found the same thing here for branch retinal vein occlusion, a good improvement for 2 to 3 months, which wore off again. Now, some people concluded from these studies that steroids do not work for retinal vein occlusion, but clearly they do. They just thought the drug lasted for 6 months, and they took out the primary endpoint at the wrong time. And here again, you can see comparing the patients that had edema for less than 3 months prior to entry into the study compared to those that had for more than 3 months, showing again that the patients that had the edema for longer got the worst results. So early diagnosis and treatment is important in RVO, and this is the chances of getting a 15-letter improvement in the second treatment cycle compared with the people who had sham or got the active treatment the first treatment cycle. Patients who were treated from the get-go had a 3 times chance of, in all these, across all groups, for getting a 15-letter improvement. So what they did here, they didn't achieve their primaries. They had 2 studies. They combined the 2 studies, and they made the new outcome, without doing any further trials, the time to the first gain of 15 letters. And clearly the Ozurdex-treated eyes here did much, much better, and they were able to get registrations in many countries, but not all. Unfortunately Australia, but the US and Europe, they were able to get registration for RVO. And of course, intraocular pressure goes up with steroids and came down again when they went on treatment. There was very little cataract progression, but you're not going to see cataract progression in a 6 or even a 12-month study. It takes 1 to 2 years before you start getting secondary cataract. So this is, again, one of our studies, a Beverdex study, but we could give it every 4 months. And this shows here the central macular thickness. Clearly, Ozurdex is wearing off at 4 months in many, many eyes. So 6-monthly dosing with Ozurdex is going to, it's not going to get the ideal outcomes that you could get if you used it more intelligently. So then Novartis ran head-to-head studies, ranibizumab versus Dex implant. They gave ranibizumab 3 monthly doses and PRN, and they give Dex implant just at baseline, and they took out the outcome at 6 months again. So we said, well, if you take out the outcome of 6 months, the Ozurdex will have worn off, and they said, well, that's the label, so that's what we're going to do. So these studies were really meant to show that the label was wrong, not that the drug didn't work. And they found here for the BRVO study that both drugs worked well at 2 months. Then the Ozurdex wore off in visual acuity here around 3 months. And again, with the central macular thickness, the Ozurdex wore off. That, of course, ranibizumab treated PRN did very well. And here's the intraocular pressure peak. See the way they've got the y-axis here. It extends the entire jump, which is only actually about 4 millimeters of mercury. And the same with Sen and CRVO. Both drugs worked very well to start with, but the Ozurdex wore off at 3 months, and the same with central macular thickness. So it's a head-to-head. Really, it shows that in the first couple of months they did very well, but they chose a primary, which is always going to find that ranibizumab did better than Ozurdex, but it didn't convince me. Same with the intraocular pressure. So I'd like to finish with a study from Yong He's group in South Korea, I think there's a very good study, really a real-world type study with an open-label study of patients receiving Ozurdex for a retinal vein occlusion. And these are the standard eligibility criteria, and the primary endpoint was the mean change in BA from baseline to 6 months. And you can see here that it was quite a good group to study. They had, on the bottom 2 rows here, that the mean vision was 50 letters, which is 630 or 2100, and it means they were quite swollen, about 500 microns. And here we have a very good improvement here at 1 week. There was a 10-letter improvement at the 1 week time point, which held up for the extent of the study, and they got a very statistically significant improvement compared to the baseline level at 6 months. Intraocular pressure went up, it was reasonably controllable. There's quite a good graph here. So there were some eyes that peaked above 35 millimetres of mercury. It does happen with Ozurdex. This is it's at less than 5%, but it can happen. They had some eyes here in purple on triple therapy, but no eyes required to go to surgery, and you can see that the intraocular pressure medication usage was not excessive. It was only in a small proportion of patients throughout the first 12 months of the study. Mean central macular thickness, the same thing that we saw, it went down immediately, peaked at 4 months and 8 months because the drug's wearing off at 4 months, but they kept it down to quite a good level throughout the study. So the number of injections received, approximately a quarter of the eyes, or a bit over a quarter of the eyes, I got away with just 1 injection over 12 months. We had about 20% had 2, and the other half had the maximal 3 injections over the 12-month period, and the number of injections didn't correlate with any of the things, the type of macular edema, the non-perfusion, or the area of macular involvement. So in conclusion, from this study, eyes treated with BRVO had very good improvements in vision and reduction in central retinal thickness, and the safety profile was consistent with previous studies. How do I use steroids for RVO? It's pretty straightforward. If it's phakic eyes, I don't like using steroids because I don't like to have to cope with a cataract in a patient with retinal vein occlusion. As we all know, these patients tend to need, many of these patients still having treatment 2 or 3 years later. So I generally start with anti-VEGF, and I'm reluctant to switch. Maybe I'll do that after 6 to 12 injections. But if it's pseudophakic, I'm getting a sore wrist, I start straight up with steroids as first-line treatment and pseudophakics for branch retinal vein occlusion and central retinal vein occlusion. Thank you.
Thank you, Mark.
It gives me great pleasure to introduce Professor Jennifer Kang-Mieler, who's actually a biomedical engineer by training, but has really developed the field of long-acting drug devices into her own. And for those who are not aware, she's actually part of the dynamic duo together with her husband Bill Mieler, who are huge supporters of the APVRS. And I'd like to welcome both of them to Malaysia and thank them very much for making the trip from Chicago to share with us their experience today. Jennifer.
Thank you, Ken. I'd like to thank Ken and the organization committee for this kind invitation. Today I'm going to talk about the drug delivery system, particularly targeting the posterior segment, whether it's delivering anti-VEGF or other agents. I do have a U.S. patent and also international patent pending on the Microsphere thermoresponsive hydrogel drug delivery system, which I'll be talking about as part of my presentation. And I also do receive NIH research grant. So with the anti-VEGF being available for treatment, now we can administer monthly or even bi-monthly injections, and knowing that a lot of our patients will either maintain or improve their visual function. However, the burden of monthly or even bi-monthly injections on patients, physicians, or healthcare cannot be ignored. If you look at the number of intravitreal injections performed, in U.S., Medicare population in U.S., intravitreal injection was done about 4,500 injections in 2001, which increased to almost 2 million in 2012. And it has been projected this injection number will be close to 7 million in 2017. And this is just looking at US numbers. So this is actually a big clinical problem that we like to actually solve. We do know that in the eye, it's a very special place. We can actually deliver drug in multiple places, whether it's a topical, transcranial, or even intravitreally. But we do know that intravitreal injection is the most efficient, direct way to deliver to the posterior segment. But there are some complications and potential considerations you do look at, potential infections or detachment of the retina, cataract formations. But really the biggest challenge is the bolus amount of drug delivered to the eye. What do I mean by that? What it is, after injection, the eye is experiencing high concentration of the drug, which then, with the short half-life, with the fast clearance, rapidly decrease the amount of the drug exposure to the tissue. So the eye is experiencing this high and low concentration, which can be either toxic or can be ineffective. And what we really need is something that's sustained deliver over time in a smaller dose that can actually achieve a therapeutic goal. And we think that we can actually do this with the drug delivery system. Now, let's look at the current FDA-approved drug delivery system, and I'm going to really focus more on what's coming in the pipeline. Really, if you look at the FDA approval system, there's only 3 drug delivery systems that can be currently used clinically. These are Retisert, Ozurdex, and Iluvien, and these are all solid implants that are delivering corticosteroid drugs to the eye, whether it can be delivered for several months to even over a year. And I'm not going to go into too much in details, but they do actually work really well by degrading the polymers that encapsulate these drugs over time. But what are the challenges? Why can we use those same system to deliver anti-VEGF? Well, one of the things that really make the anti-VEGF delivery system challenging is the large molecule size of the protein itself, as well as the delicate nature of the protein. So the interaction between polymers and protein actually can be quite tricky, as well as how much drug is going to be available and how long we can actually deliver because of this nature of the protein, and that actually poses a lot of challenges. So let's look at some of the drug delivery systems, and some are going to be focused on anti-VEGF, some are actually on other drugs such as corticosteroid. The first technology I want to talk about is microneedles. These are micro-sized needles with the injector can deliver targeting the suprachoroidal space. Now, Clearside Biomedical is a company in the U.S. that actually obtained FDA approval for clinical trials use of their device. Currently, they do phase 2 and phase 1/2 trial looking at the injecting translumin for the non-infection uveitis, looking at the Peachtree and the Dogwood trial. In their trial, what they noticed that there's a definitely visual acuity improvement, reduction in retinal thickness. There's really no serious adverse events associated with the treatment, and really no steroid-related increase in IOP with these patients. There were some few minor adverse events were reported, such as decrease in vision, eye pain, or the associated macular edema. But overall, the system seems safe and effective. Using this technology, they're now moving into a retinal vein occlusion space. They're just sort of completed phase 2 study, Tanzania trial, where they looked at the injection of suprachoroidal TA versus, in conjunction with anti-VEGF injections versus anti-VEGF injections alone. And what they found is the combination study actually requires 60% fewer injections of anti-VEGF, and with that, they're actually looking into phase 3 studies. Again, similarly, they're also looking at diabetic macular edema. We're looking at the suprachoroidal injection of TA alone with or in combination of anti-VEGF, and they're expected to have data at some time this year. The next system is the microcatheter. Again, microcatheter is targeting suprachoroidal space for the drug delivery system. So idea is that using microcannula, you insert through sclerotomy, and the lighted tip actually guide the surgeon to the targeted site. And you can then, once you reach the target site, can actually deliver the appropriate drugs or agents. Safety studies have shown that there's really no serious intraoperative or postoperative complication with this technology. Janssen Biotech has actually used technology to actually deliver the cells. This is really more for the gene therapy or cellular therapy rather than the drug therapy that we've been talking about, but it does have a really good outcome. Their phase 1/2 clinical study have shown that the use of this technology with the delivery of a human umbilical tissue-derived cells actually really improved the dry AMD patients. The patients received 50 microliters of the cells in a single injections, and the eyes that received the treatment improved 4 to 5 letters, where the compared to untreated eyes. And there was really about a 15% rate of retinal detachment, but really no other negative side effects. So again, this is not for the monthly injection of anti-VEGF, but perhaps for gene therapy or the other cellular-based therapy. Encapsulated cell technology uses a combination of the material as well as the cells. The system consists of cells that have genetically produced the particular drug they're actually encapsulating this semi-permeable hollow fiber membrane. So these fiber membrane will actually protect the cells from the body as well as allow the drug or the agent to diffuse out of the implants. And these implants are placed in vitreous and can be retrieved, and they've shown that they can release up to about 18 months. Neurotech is a company in the U.S. that actually produce and studies the system, and NT501 is their hallmark study. Looking at a phase 2 study, they've shown that there's increased retinal thickness and stable vision in the treatment of GA associated with the dry AMD and RP patients, and some patients actually had positive impact after 15 months after the post-implantation. They're also looking at the phase 2 study of MACTAL as well, and so this is actually something they're continuing. Now, with this positive results, they now move into look at how to inhibit VEGF. So they actually remodified their system a little bit more to allow a lot more cells to be encapsulated within the technology. And their phase 1 study, the safety study, looked really good with some patients that showing this clinical efficacy with the system. They began a phase 2 study with a higher dose, but unfortunately they actually discontinue it in 2016 due to the large number of patients requiring the medical injections. So unfortunately they're not going to be pursuing this technology for the anti-VEGF, but this is something we can perhaps use for other agents. Replenished micropump is an electromechanical system that can actually deliver either continuous or bolus amount of drug, whether to the anterior segment or posterior segment. This is a reservoir that sits outside of the eye and that is connected to the anterior or posterior segment by the cannula. And what's really interesting about the system is that you can actually program it. You can program it to deliver once a day or continuously throughout the day, and you can actually refill the reservoir using small gauge needles. Mark Humayan and colleagues are the ones that are actually developing and testing these systems, and their recent study actually demonstrated the safety and surgical feasibility of the pump in patients with DME. In fact, their study has shown that it's safe to implant and for a period of about 90 days, and the implant was able to deliver anti-VEGF dose within the 20% of the targeted amount in 7 out of 11 patients. So they will continue to look at this technology in the space. For the next couple minutes, I wanted to actually talk about some of the things that we're doing in my laboratory, which is using the Microsphere hydrogel delivery system. So I have a biodegradable microspheres that can actually encapsulate anti-VEGF or any other agents, and that's actually embedded into biodegradable thermoresponsive hydrogel. And hydrogel will confine the microsphere to delivery sites as well as provide another layer to prolong the delivery. Now, the hydrogel is interesting that it's a thermoresponsive. So at room temperature is a liquid-like, so you can actually inject using small gauge needles, and it will become a solid gel at body temperature. And we're looking, we can inject it intravitreally or subconj or even topically. We have recently shown that our system can actually have initial burst of about 13 micrograms of aflibercept, then continues to release about 0.065 microgram per day for over 200 days. That's over 6 months period of time. Not only that we can release for 6 months, but the release sample is bioactive. In fact, we have demonstrated that they can actually reduce the CNV lesion size in rodent models, and this similar treatment efficacy as the bolus injection of the aflibercept. And we have also demonstrated they can actually also work for ranibizumab as well. We're now actually looking at the non-human primate mice to see if we can actually demonstrate further the efficacy of our system. We know that we can deliver over 6 months in the monkey eyes with the constant level about 0.37 micrograms per day of aflibercept. We also looked at the safety. We inject these eyes and follow biweekly for 6 months, looking at the OCTs, ERGs, and FAs and clinical exams. And here's an example of OCT compared to control eyes, where there's no difference between the treated or untreated eyes. and when OCT or ERGs are at phase. And here's a histology of the at 6 months. And this particular animal, we inject a non-degraded hydrogel so that you can actually see in our histology, again, there's a very minimal inflammations or changes to the eye. So finally, I'm going to like to summarize. There's a variety of approaches to improving drug delivery system, and I'm only talked about very few. There are many more technologies and techniques out there that are trying to address this problem. Intravitreal injections and the use of the solid implants are the only thing we have right now, but I do believe that the advances will continue to occur with either new drugs or the new techniques to deliver these drugs.